Thank you for joining us for this evening's webinar. The Vassar Center for BRCA at Penn Medicine's Abramson Cancer Center is the first comprehensive center devoted to funding research across the globe, educating providers and patients, and advancing care for individuals with BRCA1 and BRCA2 gene mutations. Today's program for physicians and other healthcare providers will discuss genetic testing for cancer predisposition syndromes, panel testing including BRCA and other genes, genetic research updates, and more. As always, this presentation will be archived and available for viewing later this week at vassar.org/webinar. And of course, please feel free to submit questions throughout the course of the presentation. I'd like to introduce our speaker, Dr. Susan Domchek, who is a board-certified medical oncologist, Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, Executive Director of the Vassar Center for BRCA, Director of the Marion and Robert McDonald Cancer Risk Evaluation Center at the Abramson Cancer Center, and a Senior Fellow at the Leonard Davis Institute of Health Economics. Dr. Domchek has committed her career to pursuing research related to genetic susceptibility to breast and ovarian cancer, particularly with regard to risk assessment, screening, prevention, and treatment. She is especially interested in the development of targeted therapeutics in this population, as well as the long-term impact of risk-reducing interventions. And Dr. Domchek, the floor is yours.
Thank you very much, Sam, and thanks everyone for joining tonight. I wanted to emphasize a point of the prior speakers, which was the goal of this webinar was really to try to answer your questions. Thus, we had asked in advance for questions to be submitted, and I'm really going to spend most of the time giving some brief introduction to the topic, including incorporating a lot of the standard questions that were asked, and then directly answering many different things. So please feel free to ask questions along the way. I'd also like to mention that in the context of this, I'm really going to be using BRCA1 and BRCA2 as examples, but I'm going to be also discussing other genes. An hour isn't long enough to cover all of cancer genetics, but hopefully you'll feel we've provided a good overview. So to get started, I just wanted to, because this is a broad topic, and we really hope that we have brought in internal medicine and gynecologists, as well as people who are more specialized in this field. But I wanted to just make a few comments about what the current recommendations are for genetic testing. So the U.S. Preventive Services Task Force, for instance, their prior recommendations were to consider BRCA1 and 2 testing for women who have family members with breast, ovarian, primary peritoneal cancer, with specific recommendations as listed here, and recommended against testing for those whose family history was not associated with such an increased risk. I'll make a comment that there are now draft recommendations which look slightly different, and the comment now for recommendation testing is women whose family history or ethnic ancestry is associated with an increased risk for harmful BRCA mutations, which is a slight but potentially important modification. These were the draft recommendations, and we're waiting for the final recommendations, but this does bring up a topic which we'll discuss later, which is that individuals of Ashkenazi Jewish descent have a much higher risk of having a BRCA1 or 2 mutation, and this does appear to provide a sort of window into justification per these guidelines for testing in that population. So just a little bit about a historical context as well. BRCA1 and 2 were cloned in 1994 and 1995, and the first commercially available testing was in 1997. And these were identified first, BRCA1 and 2, as well as all other high-risk penetrance diseases, Lynch syndrome, which causes colorectal cancer and uterine cancer syndrome. Other genes like CDH1 were all first identified in high-risk families, and therefore the risks that we know to be associated with mutations in these genes were first derived from families with multiple cases. And so these risks were assumed initially to be very high, and initially the efficacy of interventions was quite unknown. And we actually even had to start with a counseling and management framework, and this was derived from things like reproductive counseling, but also things like neurogenetics, such as Huntington's disease, which is really a different context. And thus, when genetic testing started, it really was limited to particularly high-risk families. And I think that what you've seen over time is a broadening of the individuals who are eligible for testing with further discussion about who exactly we should test. So in this time, since 1994, 1995, we have learned quite a bit about these various mutations in these various genes. And specifically for BRCA1 and BRCA2, we understand that there are high risks of breast cancer with lifetime risks up to 70%, ovarian cancer with lifetime risks up to 45% with BRCA1 higher than BRCA2. We know that particularly for BRCA2, there's elevated risks of pancreatic cancer and particularly severe prostate cancer. But we also have learned that our interventions can work. So RSO, risk-reducing salpingo-oophorectomy, decreases ovarian cancer risk. It has been shown to improve mortality, studies that we and others have done. We know that mastectomy potentially, fairly obviously, decreases breast cancer risk, and that screening MRI downstages breast cancer diagnosis. We also know that there have been specific therapy changes that have resulted by our knowledge of BRCA1 and BRCA2 mutations. I'm going to review that in more detail, but from an oncology perspective, we now treat particularly breast and ovarian cancers differently if we know that there's a BRCA1 or BRCA2 mutation present. And finally, which will be discussed towards the end because there were specific questions about this, for BRCA1 and 2, there are reproductive implications both for things like preimplantation genetic testing and also for BRCA2 specifically for a disease known as Fanconi anemia, which is a recessive condition. So the and I'm looking at questions as we go, so I'll get to these as we move along, but thank you, keep sending them in. So just to get started in terms of the therapeutic issues, since 2014, there have been multiple FDA approvals for drugs called PARP inhibitors in BRCA1 and 2 associated cancers. And in teal, I've listed with the arrows the indications for ovarian cancer, and this includes both in refractory disease, but most excitingly, earlier this year came the approval for first-line maintenance, meaning individuals with ovarian cancer associated with a germline BRCA1 or 2 mutation, after they receive chemotherapy, they receive OLAPARIB maintenance, and this significantly prolongs the time to progression and has been associated with a significant improvement. So we absolutely test all patients with ovarian cancer. That's the goal. And one thing we do know is that people with a past history of ovarian cancer before all this therapeutic information sometimes have not been tested. I'll talk about that more later. There have also been 2 approvals with OLAPARIB and talazoparib for BRCA1 and 2 related breast cancer. Other data, and this is one of these approvals, it's called the OLYMPIAD study. We were very involved in this study. And this looked at OLAPARIB monotherapy in BRCA1 and 2 mutation carriers with metastatic breast cancer. And these women and men were randomly assigned to receive OLAPARIB or physician's choice chemotherapy. So this is the only study to date that has directly compared a PARP inhibitor to chemotherapy. This was a randomized phase 3 trial. And importantly, the overall response rate by something we call blinded independent central review, or BICR, which is just an independent way to establish whether cancer has shrunk, showed that the response rate for OLAPARIB was 60% versus 30% in the chemotherapy arm, and the time to response was roughly similar, meaning it didn't take any longer for OLAPARIB to shrink the tumors compared to chemotherapy. It was also demonstrated that individuals receiving OLAPARIB had a longer time till their cancer grew compared to standard of care chemotherapy. And really importantly, there was an improvement in health-related quality of life. So in summary, OLAPARIB, a PARP inhibitor, in metastatic BRCA1 and 2 related breast cancer resulted in a doubling of the response rate, an improvement in progression-free survival, and an improvement in quality of life. This is particularly important for the 10% of triple-negative breast cancers who have BRCA1 and 2 mutations. Until this time, there had been no approval of a drug other than chemotherapy for triple-negative breast cancer. So this was very important, which occurred in 2018. We've also shown that in the first-line setting, if you receive OLAPARIB first in the metastatic setting before other chemotherapy, there's also a survival benefit. So it's very important that we know the status of BRCA1 and 2 mutations in these populations. In addition, there is now a large adjuvant trial, meaning these are individuals with early-stage breast cancer who get all their usual therapy and then have been randomly assigned one-to-one to OLAPARIB versus a placebo, which is the standard of care in this setting. This is 1,800 individuals. This study just closed about a month ago, so hopefully within the next year or two we will get results about whether or not we can prevent relapse in BRCA1 and 2 mutation carriers with the use of a PARP inhibitor. There's also been work done at Penn and other places looking at PARP inhibitors for pancreatic cancer. We had published studies in 2015 and 2018 demonstrating that first OLAPARIB and then rucaparib could result in responses to these drugs. More recently, Kim Rees-Binder, who is on faculty at Penn, has looked at GERMLINE and SOMATIC BRCA1 and 2 mutations as well as PALB2 mutation carriers and shown that rucaparib is highly effective. And finally, at ASCO this year, which is our big oncology meeting, there was a study called POLO, which randomly assigned metastatic pancreatic cancer patients who had received platinum-based chemotherapy to either placebo or OLAPARIB, and OLAPARIB resulted in an improvement in progression-free survival. So there's multiple indications that it's important to know status. There are evolving data in prostate cancer as well, which in the interest of time, I'm not going to be showing you. So one of the key questions that I'm often asked, and I will tell you that this is sort of this rapidly evolving subject, is who should get testing for BRCA1 and 2 mutations. And again, to put this in context, in terms of the benefits of testing, we can identify individuals at risk. We can offer them preventative opportunities, such as oophorectomy or mastectomy. We can commence early screening with things like MRI. And we can change, systemic therapy, including targeted therapeutics. Some of the potential risks that have been evolving over time are things like cost. As we'll talk about later, the costs of genetic testing have really come down quite markedly since the initial launch of the tests back in the late 90s. There are findings called variants of unknown significance, which are changes in the genetic code that we're not sure impact the function of the protein or not. Variants of unknown significance can be very difficult for patients to understand, and there are some data that unfortunately individuals with variants of unknown significance are often managed incorrectly, meaning it can be very tempting that if an individual has a strong family history of cancer to assume that the variant of unknown significance is why they developed cancer and to do things like remove ovaries. But that should not be done. Variants of unknown significance, patients with variants of unknown significance should be managed as if they have negative genetic testing and be managed on the basis of their family history. And therefore, VUSs can be complicated. The interpretation can change over time, so you have to have a way to kind of keep track of that information. And finally, when testing initially started back in the late 90s, the feeling was that this could be a burden for individuals with kind of nothing to do about it. Again, an analogy to Huntington's, where the penetrance of developing Huntington's disease is 100%, and there's really nothing that has been proven to work in that disease. But as things have evolved, although there is a psychological burden and there are difficult decisions to make, it's certainly not the same type of information as in that scenario. It's also important to realize that there are different considerations in different stages of care. If someone has metastatic pancreatic cancer then they're not making decisions about mastectomy. They're really getting this information about therapy. It does have implications for their family members, but it is very different to test a 67-year-old with metastatic pancreatic cancer and a 25-year-old who has never had cancer and is going to have to make some challenging decisions about management of her breast and ovarian cancer risk. There are guidelines, which I'll show you in a minute, which are more specific about what we mean by a family history, a personal family history from the National Comprehensive Cancer Network. And there has been a ton of debate about where these thresholds should lie. The costs are coming down. Some of the downsides to testing are, improving. And so now the question is, should we kind of, test more people? Some of the challenges are that we don't exactly know what it means to have a mutation in a gene and have no family history. And I will comment that not having a family is different than not having a family history. If your dad and mom were only children and your grandparents were all only children, you don't have enough people to know what the penetrance of risk is. But if there are tons of people in the family and there's no cancer, then it may be that that individual has a lower risk of cancer than others, and that makes things additionally complicated. But the fact is that certain individuals have a much higher chance of having a mutation such as BRCA1 and 2 than others, and these are high penetrance gene mutations. And as we talk about all this, I think it's really important that we don't miss the people at the highest risk. And I'll give you a specific example. Again, ovarian cancer patients have a 10% chance at least of having a BRCA1 or 2 mutation. Some studies show that's as high as 15 or 17%. So every patient with epithelial ovarian cancer should get genetic testing. However, there have been studies that have been done that show that survivors of ovarian cancer out there in the community, that as few as 10% of them have had testing. And even in 2015, a study showed that only 30% of ovarian cancer patients in Georgia had undergone genetic testing. So we're really not getting the individuals who are at the highest risk, and so we can't forget that as we talk about everything else. All right, so what about, whoops, and then of course, sorry about that, one of the other questions is, should we test everybody, or should we test certainly the consideration of testing people who are of Ashkenazi Jewish descent, which I'll again talk about later. So the NCCN guidelines have been criticized for being too dense, and as you can see on this slide, they are fairly dense. There is a concerted effort to streamline this, but it does have a lot of useful information. But in the interest of making this a little easier, I've condensed this to say that individuals who have breast cancer under 45 or breast cancer under 50 with relatives, somehow triple-negative breast cancer got lost off this slide, but triple-negative breast cancer, ER/PR, HER2 negative breast cancer under 60. Every ovarian cancer patient, every male breast cancer patient, any patient with pancreatic cancer or metastatic prostate cancer, or is Ashkenazi Jewish with breast cancer, or has a BRCA1 or 2 mutation found on somatic sequencing. All of these individuals should be strongly considered for genetic testing. And again, we'll talk about individuals of Ashkenazi Jewish descent in a minute. So that kind of covered some of the submitted questions, but I'm going to go through some of the very specific ones that were asked in more detail. So the first was a very important question about legal protections. So I think that, when especially individuals who have, internists or gynecologists who have not been doing genetic testing on their own want to know a little bit more about some of these specific issues. So let's talk about the legal protections. There are two sort of buckets of ways to think about this, but the main one is GINA, which is also known as the Genetic Information Non-Discrimination Act. And GINA has sort of two components to it. So on the top left, you can see that GINA actually does have protections related to employment. So for instance, it is against the law for your employer to use family health history and or genetic test results in making decisions about your employment. So that is illegal. In terms of GINA and health insurance, it's against the law for your health insurer to use a genetic test result or family health history as a reason to deny you health insurance or decide how much you pay for your health insurance. On the bottom left, however, it does show that GINA is not fully comprehensive. It does not cover life insurance, disability insurance, or long-term care insurance. It does not apply to employers with less than 15 employees. And it does not have to apply to federal employees or those in the military, although they have separate protections. So I think sometimes people can be surprised about the issues of life and disability insurance. We don't exactly know how these insurers are using genetic information. In the past, they've largely used family history for their actual personal and family history as their actuarial table. So we know, if you had already had a history of ovarian cancer and then applied for life insurance, that was going to be considered. If you had a strong family history of cancer, that's also considered when you apply for a life insurance policy. So how many insurers are really using specific genetic information is not clear. We try to keep an eye on this, but it is not clear. And some people choose to get, if they've never had a cancer, consider getting insurance before they get tested. But the key is that this type of insurance policy could use genetic information, is not illegal. Now, the Affordable Care Act on the bottom right protects those with pre-existing conditions. And so this is another component. HIPAA also has privacy protections in it. So there's these different layers of protection. I will say that GINA's never been challenged yet, and that's in part because GINA went into effect in 2008, and the Affordable Care Act kind of came about pretty quickly after that. If the Affordable Care Act crumbles, it may be that GINA will become more important related to genetic testing information. Another question that was asked was about polygenic risk scores. And so, and polygenic risk scores, just to kind of take a step back, we've long known that individuals with BRCA1 or BRCA2 mutations, that different families look different from each other. Some families only had ovarian cancer, some only breast cancer. Some people with the exact same BRCA2 mutation have breast cancer early or late or never. And so we've always understood that there's this variability in penetrance of BRCA1 and BRCA2 mutations that can impact a lot of these things. We obviously consider that environmental factors and reproductive factors could be important, although to date, when they've been examined, they have a modest effect on risk, meaning things like, how many kids you have or how old were you when you had your period. Those things have a pretty modest impact on BRCA1 and 2 carriers. But one other thing that has been out there is whether there can be the variation in genetic risk. And by the way, in this slide, all I'm showing is that in the initial study back in 1995, which is the same families where they were able to clone BRCA1, all these families had to have at least 4 cases of breast or ovarian cancer. This is the highest reported lifetime risk of breast cancer at 87%. That's the figure that Angelina Jolie used in her New York Times op-ed and is frequently quoted back to us, but is not sort of the usual range we give. There's been multiple other studies. This is not inclusive. There's many, many studies, including one that was done in 1998 looking at the 2 common Ashkenazi Jewish founder mutations in BRCA1 and showing that the lifetime risk could be as low as 40%. So the general range we give is 50 to 70%, but what stratifies people, again, there may be multiple different factors. And one of these factors can be other genetic modifiers. There's a large consortium that we work with called CIMBA, which is the consortium of modifiers of BRCA. There are now more than 46,000 BRCA1 and 2 mutation carriers through the world that we have data and DNA on. Penn has long participated in this initiative. And what has been done here is that there are things called SNPs, single nucleotide polymorphisms, and they alter risk in the general population each by just a tiny bit. So when you're talking about non-BRCA1 and 2 carriers, you know that these SNPs can alter genetic risk of cancer by just a tiny bit. But we now know about 100 of them. So if you're somebody who has all 100 bad SNPs, even if there's a tiny risk, the cumulative effect can be to increase your risk by a relative risk of 4, for instance. And then conversely, if you have all low-risk SNPs, your risk is lower. And this applies to BRCA1 and BRCA2 as well. So in this curve, what I've shown you is the black line is the average risk for a BRCA1 mutation carrier to age 80. And you can see here that that ended up being about 60%. People who have all the low-risk SNPs had a risk as, as low as sort of, 45% or so, and all the high-risk SNPs are more in the 70% range. Now, the challenge here is that that's not widening the risk high enough for us to necessarily tell people to do anything different about that information. And so this isn't we haven't been using this clinically yet, but we certainly are hopeful. Polygenic risk scores, however, may be useful in both the general population and in altering risk for other cancers. And this is a lecture I could give, an entire hour on this. So just to kind of give you an example, CHEK2 is another gene, mutations in which increase the risk of cancer, of breast cancer. Same with ATM. These mutations in these genes in general have a relative risk of breast cancer of 2 to 3. And in this case, if you layer on the SNPs from the last slide onto this relative risk, you can see, and if you use 20 as a cutoff for if we're going to do anything about it, you can see that for CHEK2, a lot of these patients don't actually have a lifetime risk greater than 20, and the same for ATM. So it may be that the most important part of these SNPs and the polygenic risk scores are for people who don't have a strong family history and don't have mutations in high-risk genes like BRCA1 and BRCA2. All right. So another question that was asked was related to the somatic versus germline and sort of how to think about all this. So just as a reminder, germline mutations, it's a mutation in an egg or a sperm. If it is passed along to a child, all cells are affected in the offspring, and so therefore they are heritable. And mutations, or what we call pathogenic variants at this point, can increase the risk of cancer if they are in certain genes. Now, it is potentially obvious, but if a cancer develops in somebody with a germline mutation, the cancer will have that mutation. So if you have a BRCA1 mutation and you develop breast cancer and you sequence the tumor, you'll find the BRCA1 mutation in the tumor. On the right-hand side, though, is just what somatic mutations are. So somatic mutations occur in non-germline tissues. So, for instance, you can have a BRCA2 mutation in a pancreatic cancer that was not in your germline and therefore is not heritable. And these types of acquired alterations are common in cancer. And so it's very common to have a somatic mutation in P53, but it is very rare to have a germline mutation in P53. The reason this is, getting a lot of attention is that we're doing a lot more somatic sequencing now. A lot more tumor sequencing is done. And so when we're doing somatic sequencing in the oncology clinic, we're really trying to identify targetable mutations and use them potentially for treatment. Now, it's always true that and use it for treatment. And so these can be ordered by, medical radiation oncologists, surgeons, pathologists. Usually it's done at the time of metastatic disease or because we're doing clinical trials. And importantly, because it's a test on a tumor sample like an estrogen receptor or progesterone receptor, generally patients aren't specifically consented for this. And it's sort of billed through pathology. At Penn, we, through the Center for Personalized Diagnostics, do somatic sequencing at Penn. In germline testing, we're identifying this in the germline, identifying people who are at risk for hereditary cancer, and this has always had a different model. Obviously, anyone can order this test. It's frequently, but not always, coordinated by genetic counselors. Genetic counselors are invaluable to this process, are incredibly knowledgeable, but it can be done at any time, and people who have cancer are not. Consent is required if you send this test, and is strongly recommended so people understand the risks and benefits of receiving this information. And counseling, or at the minimum what we consider pre-test education, should be provided. So this is why you would get this test. this is the risk of having this test. We always mention the insurance issues. We mention that if you have a mutation, that it's going to have implications for your families. And in general, if people meet the guidelines that we've mentioned above, insurance will pay for the cost of the test. However, increasingly, there are direct-to-consumer models, and there are very inexpensive tests, and so increasingly patients are paying for these tests as well. So again, germline mutations, germline findings in cancer predisposition genes are pretty common in cancer. And so what we advise is that if tumor sequencing reveals a mutation in a gene such as BRCA1 or 2, but this applies for Lynch syndrome genes as well, confirming that this mutation is in the germline can have a lot of implications for the patient and the family. So just to give like a really specific example, if somebody has had pancreatic cancer and their tumor had a BRCA2 mutation, and that individual dies and we're not sure if that mutation is in the germline or not, if you test all the kids and they're negative for that mutation, that's not as helpful as knowing that that person had a germline mutation that they're negative for. So hopefully that made sense. But we really strongly encourage that if it's seen somatically, that it is tested to see if it's in the germline or not. And a final, just a quick comment is that although there's FDA approval for PARP inhibitors for somatic BRCA mutations in ovarian cancer, that's not yet true in breast or other cancers. So the data are evolving, and we're keeping an eye out on that. So genetic testing has massively changed. In the good old days, 6 years ago, someone would come in. We would meet with them, take a family history. We would say, this looks most likely like BRCA1 or 2. We would send testing for that. If it was negative, we would consider whether or not there would be other genes that we should test for, and then we might send that testing again. However, what's occurred is that in 2013, two things happened. The main one is that basically due to issues both of patents going away and also a Supreme Court decision, there was a window created so that other labs besides the initial lab, Myriad Genetics, could offer testing. Simultaneously, there was a change in technology so that instead of doing Sanger sequencing, one gene at a time, we were doing next generation or massively parallel sequencing where you could test as many genes as you wanted on a panel at the same time, really for no additional cost of the sequencing. That doesn't mean there's not additional cost of analysis, and that doesn't mean that there's not additional downstream costs. And so now, more commonly, although we still assess the patient, oftentimes the multi-gene panel is sent for lots of different genes, and then we get the result. And sometimes there's not much assessment. First the panel sent, and then we do it on the back end. And as we discussed with somatic, you get the result first, and then you go back and do sequencing. So in addition to, BRCA1 and 2, there have been a number of other genes that have been described, mutations in which are associated with cancer risk. So up here on the left-hand side, we have things that are rare, but very high penetrance, meaning the lifetime risks are quite high. So these include BRCA1 and 2, but also things like CDH1. I'm going to pull out CDH1 particularly because CDH1 has a very high risk for the development of stomach cancer. In the past, if you tested for CDH1, you were doing so in the context of multiple cases of hereditary, diffuse gastric cancer. Okay, so this wasn't a single case. This was multiple cases of, this linitis plastica, this diffuse gastric cancer. And in that context, people who had CDH1 mutations were counseled that their lifetime risk of cancer was 80%, and therefore they should prophylactically have their stomachs removed at age 20. So I just want you to keep that in mind as we talk about layering lots of genes on panels and testing for them, that within that mix, there's a gene like CDH1. Other genes that you can see, like MLH1, MSH2, MSH6, are Lynch syndrome genes. Mutations in these genes have high risk of colon and uterine cancer. We then have a cluster of genes in here which have sort of a moderate risk of cancer. Check2 and ATM I've already mentioned, which have relative risk of breast cancer in the 2 to 3 range. And then over here are these SNPs identified by genome-wide association studies with relative risk of less than 1.5. So it's become complicated because there are many, many labs that you can now send testing for. So this gets into people asking about what lab should we send to, what genes should we send. So there are many labs, Ambry, Myriad, Invitae, Color, GeneDx, many, many labs. I have not, before someone sends me an email, it's not meant to be inclusive, it's meant to be illustrative, as is this slide, which just shows you that depending on the lab you go to, there are many genes that can be on these panels. And this isn't meant to be a complete list. Of note, at Penn Genetics, we don't tend to send huge panels. We tend to send more limited panels where we have a clear idea of what the genes are, what the risk of cancer is related to those genes, and likewise. And so, you know, it's important that as you kind of get used to what you're ordering, that you know what's on the gene panel. What are the genes that you feel comfortable with, and do you know kind of what you're sending on this? And as I'll kind of get you more, the choice of the test depends on a lot of different things. It depends on the clinical situation for sure. So if you have a family where you have, you know, colon cancer and breast cancer and ovarian cancer and uterine cancer, so you're thinking of both Lynch and BRCA1 and 2, you absolutely want to include all those genes on the panel. Some patients get the very know up front that they're very anxious. The more genes that you put on a panel, the more likely you are to have a variant of unknown significance. And therefore, some people will prefer to have smaller panels that really are just getting at the most important information, the things that are going to change their management the most. Some individuals, if you talk to them about that gene called CDH1, do not want it on their, do not want it included because they don't want to be faced with that kind of decision, especially in the absence of a family history. Insurance issues can matter. Sometimes people's, you know, insurance might push them to one lab or another. It can matter about out-of-pocket expenses, turnaround time, and another thing is that some labs have the ability to do what we call reflex testing. Start with a smaller panel, get that information, then decide, and then the patient has a little bit of time to think about how much they want to do. So this particular slide is on our website. It goes through some of the specific issues related to the different genes. Again, not all inclusive. We don't have every gene here, but you can see that there are some genes that you probably haven't heard much about, like BRIP, RAD51C and D, that are associated with ovarian cancer. And these are known to be associated with ovarian cancer. They're relatively rare, but the lifetime risk of ovarian cancer is approximately 10%. That is a range at which we do definitely consider preventative removal of the ovaries, not at the same age as BRCA1 and 2, slightly later. So here I'm going to divert for a moment because there was a specific question about the timing of oophorectomy for BRCA1 or 2. So BRCA1 and BRCA2, as mentioned before, are both strongly associated with ovarian cancer. The lifetime risk for BRCA1 is up to 45%, and the lifetime risk for BRCA2 is 10 to 20%. BRCA1 related ovarian cancer risk, the risk is higher and the risk is earlier, meaning that development of ovarian cancer can occur earlier. The lifetime risk of ovarian cancer prior to age 40 for BRCA1 is approximately 3%. And therefore, we do talk about removal of the ovaries and fallopian tubes by age 35 to 40 or once childbearing is complete for BRCA1. For BRCA2, because the risk is somewhat lower and a little later, that is more like 40 to 45. There is a lot of discussion out there about whether we could just move fallopian tubes and then later remove the ovaries. That is, based on data from Ron Drapkin at Penn and others related to the fact that many ovarian cancers start in the fallopian tube. However, at this point, you know, the standard of care is removal of the ovaries, And removal of the fallopian tubes is generally done on a research study. So we have an ongoing research study that we participate in. It's a national study called WISP, run out of MD Anderson. And so we strongly encourage people to do those types of studies. At any rate, you can see on this list, the different genes and the associations with the different cancers. I will tell you also, though, when you look at this, and that some of the genes are very strongly associated with risk. We know very much about them. We've done prospective studies, and others, our studies are relatively weaker design. So unfortunately, this is going to continue to evolve over time. But this gives you ideas of the different genes. All right. So how do you choose a lab? We mentioned that there are issues like insurance coverage, what genes are on there, whether or not you can do reflex testing. Some companies also offer free testing to relatives within 90 days of the test result. There's a little bit right now going on that this is changing all the time. So the various labs sort of are offering sort of different things, and so it's really it's hard to be too precise about this because things change. So most commercial labs do offer multi-gene panel testing, so that's not usually sort of the main driver of a decision. So when we talk about these other gene mutations, I think first we take a step back and we say, okay, what did we learn from BRCA 1 and 2? And we learned that we can identify people at risk. We also learned, by the way, that in families where an individual is negative for the known BRCA 1 or 2 mutation, the risk is the same as the general population, which is great information. But we do know that there's this variable penetrance. Not all the risk is the same. We know that we can help with disease prevention. We know that there are therapeutic options. So when we get to these other genes, when we apply this paradigm with these other panel tests, we don't have that same knowledge base about a lot of this stuff. Particularly with therapeutics, there are ongoing studies, but I want to emphasize that things like oophorectomy, many of these genes like CHEK2 and ATM, which are the most common genes that we find mutations in when we do panel testing, there's no role for oophorectomy in the absence of a very striking family history. So we have to be extremely careful not to sort of layer on how we manage BRCA 1 and 2 to these other genes. There are gene-specific recommendations for clinical management. They're part of the NCCN. We've written papers about this. But right now they're based on expert opinion. They're not based on data regarding clinical utility. And again, I specifically am calling out that CHEK2 and ATM should not be managed the same way as BRCA 1 and 2. And in addition, this challenge of finding these things we consider high penetrance gene mutations in syndromic genes like CDH1, and in the absence of the syndrome makes it very challenging to manage. And we have had families with no gastric cancer have to make a decision about whether or not they're going to take their stomachs out because of a finding of a CDH1 mutation. And the argument has been made, that sometimes you find cancer there, and therefore you save their lives, and other people, some of our patients have felt that we've ruined their lives. So it's all a matter of, counseling and education, and it's a very complex issue. Okay, what about, I wanted to knock off one more question while I was in this section because I was asked about men. I think it's super important. We try to emphasize this, but it cannot be stated enough. If you lined up all the mutation carriers in the world, 50% of BRCA 1 and 2 mutation carriers would be men. There is definitely an impact on men. This is more for BRCA 2 than BRCA 1. Why these similar? These are both of these genes, the proteins, complex with each other, but they are different susceptibility syndromes. So again, BRCA 2, the lifetime risk of prostate cancer is as high as 25%. And again, this is aggressive prostate cancer. This is not the kind, you die of at 85, die with at 85. This is the kind that you die of. PSA screening actually seems to work reasonably well. So BRCA, I'll say BRCA 1 and 2, although our data mostly is for BRCA 2 mutation carriers. It's not the general population. I do recommend PSA screening. The risk of prostate cancer for BRCA 1 is a little less clear, but we still view it as somewhat elevated, but that's still evolving. There is a risk of male breast cancer. It's definitely higher for BRCA2 than BRCA1. The risk for BRCA2 is maybe as high as 7%. Remember that the risk of male breast cancer in the general population is 0.1%. There's no specific recommendation for mammography, but if a man has breast tissue, which many men have, or some gynecomastia, then I do a mammogram. The risk of pancreatic cancer for both men and women is about 7% for BRCA2. Actually, we're going to get to that more because I think there was, in my rapid fire question section, I can talk about pancreatic cancer screening. And again, there's this increased risk of melanoma. So men, particularly with BRCA1, get off the hook somewhat, although there's sort of a global increased risk of cancer that doesn't tease out any kind of one particular cancer. So another question that was asked was about family communication. This is really critical. If we find a BRCA 1 or 2 mutation, we want as many people as possible in the family to know about it, because those, so that's why we often use this little phrase that we don't test people, we test families. There are legal things about this. There's been a case about duty to warn, where physicians have been sued for not warning relatives about this information. There's also been privacy violation lawsuits, so it's a little tricky. And so mainly what we do is really try to convince people that they need to talk to their relatives. We provide them things like family letters. We offer to talk to people. My genetic counselors have some communication projects going on. My colleague Angela Bradbury, offers telegenetic services. So we try to offer as many different approaches as we can. But the cascade testing is really crucial for prevention and screening. So the decision, it says testing a family starts with someone who has cancer. That's obviously not always true, but often can be. And although the decision to test is a personal one, letting people know about this information is key. When to test, because this was another question. In general, we start for BRCA 1 and 2. We do genetic testing at 25 because that's when we start breast MRI. For men, 35 is even young. 40, is kind of when we start doing things like potentially doing PSA between 40 and 45. Children are not candidates for BRCA 1 and 2 testing for different genetic susceptibility syndromes like APC, which causes familial adenomatous polyposis. We do testing in kids because we have something to do about it. But for BRCA 1 and 2, we do not test children. The other thing that's relevant in terms of the timing question is the issue about reproductive genetics. So preimplantation genetic diagnostics, are now called preimplantation genetic testing, PGD or PGT, is reproductive technology that tries to minimize the chance of passing a known gene mutation to a child. So the process is in vitro fertilization, and then screening of the embryo for BRCA1, 2, or other gene mutation, and then reimplanting the embryos without the mutation. And so this is something that sometimes is covered by insurance. Oftentimes, however, it's costly. It's obviously, certainly a process for people. It can bring up very complex emotions because somebody in this scenario has a gene mutation. So it can be, some people are very interested and others decidedly not. And so sometimes men who might be starting to have their kids at 25 or 26, if they're interested in preimplantation genetic diagnostics, we offer testing then because they might be using this information in this way. And finally, again, there's a rare condition called Fanconi anemia, where if a child inherits 2 bad copies of BRCA2, this is a condition of bone marrow failure. People can be short. They can have abnormal thumbs. There's a whole syndrome associated with it. Again, it's quite rare, and it's never been reported with 2 of the common Ashkenazi Jewish founder mutations, which is going to lead me to this. So BRCA 1 and 2 mutations are common in the Ashkenazi population, approximately 1 in 40 individuals who are of Ashkenazi Jewish descent have a BRCA1 or 2 mutation in one of 3 specific sites, which are listed here. Again, 2 in BRCA1, 1 in BRCA2. And so there has been a great deal of discussion about whether or not, because they are so common and because we can do stuff if you find a BRCA1 or 2 mutation, and some families, some Ashkenazi families, you don't have much family history because they may have been decimated by the Holocaust or something like that. Should we just offer genetic testing to all individuals of Ashkenazi Jewish descent? And so there's been studies that have been done looking at this, you know, one study sort of here looked at the cost effectiveness of it. Now, I've pulled out the table, if you will, directly as it was published in this paper. There are some of the assumptions have changed, but if you will, if you consider in the Ashkenazi population, here they assumed 1 in 50 had a mutation, that 11% of breast cancers in the Jewish population were due to a BRCA1 or 2 mutation, that the lifetime penetrance was 49%. You get the idea that they found that this was extremely cost effective, but again, this was assuming that everyone had a mastectomy. In the non-Jewish population, because it's not as common and the costs are higher because you don't just do the 3 common Ashkenazi mutations, you have to sequence the whole gene, the cost effectiveness doesn't look the same. Now, I will say the cost of the testing have come down even in the non-Ashkenazi, and these are, in the non-Ashkenazi population, they are a little more common. But this is just to show that why you would think about doing it first in the Ashkenazi population, because again, these mutations are just so much more common and the testing is a little more straightforward. So we do have a study ongoing called the BEFORE study, the BRCA Founder Outreach Project, which is looking at this issue. It's basically offering testing to individuals of Ashkenazi Jewish descent, individuals can come in through the study. They do online pretest education. They go to Quest and have their labs drawn. We give them the results back, or they choose their primary care doctors to do this. We've been trying to enroll 1,000 people in Philly, and then 1,000 in New York, 1,000 in Boston, 1,000 in LA. And we've been surprised that we've been stuck at around 600 we've been open for over a year, and we've been stuck at 600 for the last few months. So it's interesting. This is not necessarily, you know, people aren't necessarily running to get this done, and we need to investigate more about that. All right, so then I'm going to do a couple of rapid-fire questions and then look at the other questions that might have been submitted. Okay, so one great question was, do and can Cancer Genetics Lab keep updating specimens and retest for new risk genes over time? And the answer to that is they cannot hold on to DNA. I think that in general they hold on to it for 90 days. There are all sorts of different reasons for that. Some of this is privacy regulations that, you know, the companies can't just hold on to DNA. Other things are regulatory in terms of when they can submit for additional testing without it being sort of a new test. But they do update analysis. So they don't test for new genes as they have come up. You'll need a new sample. But if the individual has had a variant of unknown significance, the lab will update that information. They'll feed it back to the person who ordered the test to then provide that information to the patient. So that is the thing. If you send testing, you have to keep updating that. And there has been a lawsuit of a finding that was reclassified from a variant of unknown significance downward to a nothing, and that patient was inappropriately managed by surgery in the first place. But even worse was that it was downgraded before that finding came through. So it's important to be able to keep track of this in your charts. Okay, thoughts on high-risk screening for pancreatic cancer. We at Penn have ongoing studies looking at endoscopic ultrasound. There have been studies, particularly a study called CAPS-5, which has been multi-institutional, that looked at BRCA1 and 2 and other gene carriers like CDKN2A and STK11. CDKN2A and STK11 have particularly high rates of pancreatic cancer. Unfortunately, they're rare genetic syndromes. In CAPS-5, individuals either had endoscopic ultrasound or MRI screening, and you do find stuff. Exactly whether or not this is helping anybody continues to evolve with time. But MRI is generally not covered by insurance for screening. Endoscopic ultrasound sometimes is. Again, it's under study. It's not part of guidelines for BRCA 1 and 2, but for some of these other rare, but again, we do offer it in the context of a study. For people with a strong family history of pancreatic cancer, I think it is absolutely worth considering. How often should breast cancer screening be done for BRCA positive women? So again, we start annual breast MRI at age 25. We do it annually at 30. We add on a mammogram, so that every 6 months people are getting either a breast MRI or a mammogram. In terms of when to stop breast MRI, boy, that's a tricky one. I think that those of you in primary care know that stopping the screening, it can be a difficult conversation. So I start talking to my patients at 75 about this issue. Again, there is gadolinium contrast given with MRI, so we have to keep track of renal function. Obviously, we have to keep track of comorbidities. I use a lot of their overall functional status sort of as a guide. Another question was raised about public databases of genetic testing variants. So there are databases that you can go if you send genetic testing and you get a test result that is listed as variant of unknown significance. There are these databases that you can go to. One is called ClinVar at clinvar.com. Another one is brcaexchange.com. It might be org. Oops. Or I'm sure it's com if I put it com, but it's either com or org. So the key here is that you just would put in the variant and it will pop up what all the different commercial testing labs have called it. One caveat there is Myriad Genetics does not deposit data into public databases. So some of those will be captured through something called sharing clinical reports, but these can be really valuable resources. However, out there in the community, if you're facing difficult VUSs, we would be happy to see them and help. Because I have 1 minute left, I'm just going to say that I work with really all these great people at the Baxter Center. The counselors are incredible, and so if you haven't worked with a genetic counselor, I can just tell you that they're an invaluable source of information. So you can always reach out to us and research staff, et cetera. So, I wanted to thank everybody for helping with that. By the way, this is new for us. This is a question and answer format rather than kind of a strict lecture. I don't know if that was good or bad. We'd love your feedback. We'd love to know if you'd like us to do this again. When we've done things that are similar, the feedback we get is that people would rather just have their questions answered rather than kind of give sort of yet another standard lecture. But if you'd like a different format, we would be happy to do that. Our goals are to sort of educate, help people who are out there considering genetic testing, and in general, just try to advance the field. So with that, I think I've gotten most of the questions, and we've hit 9 o'clock. So Sam, any last words of wisdom?
Just that this will be up in probably a day or two on baxter.org/webinar, and we encourage everybody to share it out. It will be a YouTube link, so very easy to email, share on social media, and so on.
And please feel free to give your feedback, one way or the other, so that we can, find the best format to help everybody out. So thank you very much for your attention, and hope to see you next time. Okay, bye.